Thank you very much for the very inspirational lectures of the Dr. Pong, and also appreciate for your visiting and your attentions. And my position is a little bit unique compared to the many clinicians. I works as a developer and also works as a clinician. So with the development of the materials, and we tried to make some concept to be very easy, simple, and predictable. So that was the reason we have named this concept as minimalisms. I will do very short introduction of the various materials at first of the dental implant system and the tissue regenerative materials, and use the cone-beam CT with the CT viewer for the practical use, and if possible about the perioral tissue augmentations. As you see, and this is a bright implant bone levels, but previously when you use the bone level implant in the posterior side, at least 4.5 diameter implant is very safe. But bone condition usually is not good enough for that implant system for the installations, but this implant is bone level is a bright implant system with this 3.5 diameter of the bone implant diameter implant can be used for the single molar. So before we are thought that in the previously Supran is good enough for the most of the cases, but with the introduction of the bright implant system, however, the very similarly it's bone level and the tissue levels, and that can be used very commonly well in a very difficult cases, very simply. So content will be about the introduction and the short but stable implant and the narrow implant system, and already mentions of the contents CT and the perioral tissue augmentations. And in this case, the lower anterior is a very thin bones. We have to place the relatively very narrow diameter implant very simply and without the trauma, so patient feels no pains, and we have finished with very satisfactory. So when you see and in the uppers, and the patient have some already one implant systems, but that have some problem. The already labial bone is too much thin during the functions, and there will be some problems. So I decided to instruction and press the two narrow diameter implant in the lower anterior and the making of processes. As you see, with the two narrow implant, sometimes worry about the biomechanical problems on this with the canine cantilevers. But with the very stable connections of between the implant and the abutment, and we can sure of the safety, so we decided to make one cantilevers. After the final processes, and nowadays patient train so well and very satisfied. And before the surgery, as you see, after the bone resorption, mandibular bone is very too much thin and reduced. So it is relatively very difficult to place the conventional implant systems. But with the narrow diameter, we finished the surgery very simplified. So this is a video of the concept of the narrow diameter implant in the lower mandibular area, anterior mandibular areas. So very similarly, we tried to crystal incisions in a keratinoid zone areas. And, sorry. Yeah, sorry, I do some mistake. Anyway, we placed the two narrow diameter implant and tried to make a temporary crown. After finishing of the temporary crown, and the patient chewing relatively well, so finally we taking another impression for the final processes. So when you do intraoral scanning, so one is a very simply intraoral scannings without additional abutment and anything, but in this another scanning with some pro resin on the pontic areas. Usually, at first we tried to do on the crestal areas, but later on, that for the efficiency of the dental laboratory work, we tried to add the flow resin on the labial or lingual side. With a higher flow resins with the dry, that is good enough for the intraoral scanning. So through the stitching, so two images a little bit difference in the precision. So, but if you're adding some flow resins, and with that, we have a very clear images for the final processes. So with that, through the stitching in the pontic areas to follow the scanning without any of the flow resins, and with that, and we have this virtually designing. And also in the virtual articulating, in the centric and the eccentric, and the finishings, and also we selected the three-layer zirconia blocks, so we have, without any coloring and staining, we have finished and placed into the mouse, and the final process was done around 1 month before. Next, very shortly, another introduction of the short implant system, but very stable implant. So we have already, you know that we have launching a bright implant systems, and that can be used very well. And that is one type is a bone level, another type is a tissue level. The bone level is a 10 degree, very deep connection with that, and we have a relatively good stability, not so much dependent on the screw tightening. And also sink down is much less compared to the previous one. And also the length from the 7 to 50 millimeters. And recently we have launching a diameter 3.0 implant systems. Is a 1 millimeter less connection due to thickness of the fixtures. But still, and this 3.0 implant have a relatively good strength, and that can be used in the anterior to the premolars. But that is very difficult to be used for the single molars. So in the lower anterior areas, we try to press the 3.02 implant systems with the bone augmentation together. This is a 3.0 implant, and with the bone grafting together. So at that time, we used the xenograft and the collagen graft together. So this is a tissue level implant is a 20 degree angular, 20 degrees tapered walls is very stable connections. So with that, and we have a single platforms that can be used for the anterior to the molars. But for the emergency profile in the molars, sometimes we place a little bit deeply. Also, however, 7 millimeter length is the outer surface is very compatible with the 8 millimeter length of the ship line. So, however, you place the 8 millimeter length, 7 millimeter length, and the diameter 3.5 is tissue level is very safely used in the single molar. So there is various cases of them. So this is some introduction of the narrow diameter and the short implant. Is left side of the implant is a 2.5 diameter implant, and the drilling only into the cancerous and the implant pressed on only cancerous areas without grinding of the labial cortical bone. This is a 7 millimeter length implant, and is posterior side is pressed with the final processes can be used very successfully. So sometimes also we do in the with the vertical bone augmentations, and we can place the short implant is very safely, and the suprary and the 2 or 3 millimeters vertical bone augmentation was very simplified with the osteon collagenate bone and the collagen graft. And this is another case in the lower mandibular side. Especially on this side after extraction, there was a so severe bone loss vertically and horizontally. So after extraction and some months later when you press the implant, there is not so much enough bone. So we do grafting the collagenate bone and the collagen graft together. And during the follow-ups, the bone was formed very well. So this is a second molars. And before the surgery, as you see, after the severe bone destruction, or sometimes after implant removals, and there is a very severe bone defect, vertical and horizontally, and also very small remnant of the keratinoid tissues. So usually in this case, it's very difficult. So usually for overcome of that, we do at first bone augmentation and the secondary implant placement, or sometimes we do the free-gingival graft together. But in this patient, and after a little bit bone healing, we need to place the implant at some around 4 to 5 millimeters exposure in the first molar side. And so we do in a contained defect at first, we tried to place the xenograft. And over there, on contained defect, we graft the collagenate bone, and that was covered by the collagen graft. Also, sometimes we are consider about the labial or vocal flap movement, and to prevent the motions. And so we tried to nowadays place the little bit densely collagen graft on the vocal side. With the suture and with the temporaries, and the patient is around 3 to 4 weeks, 4 months functions so well. So, but still some problem is not enough keratinoid gingiva. In future, there are some needs for the free gingival graft. So we have a history of the various bone graft material and the collagen membrane and the collagen graft. Nowadays, with the combinations, and we use relatively well. So in these cases, also with the collagen graft, sometimes can be used for the to make keratinoid tissues on the buccal side, on the mucosa areas with the apically positioned flaps instead of the free gingival graft. Also, for the short implant, also into the sinus concept, we have tried to simplify it for them. And so at the time of the Bright implant launching around 6 years ago, we tried to make some simplified guideline of the sinus augmentations. So depending on the remaining bone height, 1 to 3 millimeters is lateral approaches, and 3 to 5 millimeters crestal approaches, or the 5 millimeters the bicortical fixations. With that guideline, at that time, around 6 years ago, we think that is a little bit challengeable, but during the 6 years evaluation, we became to know that that is good enough prognosis. As you see, it's one of the bicortical fixation, 3.5 diameter implant, and also 7 millimeter length. So the reason is we do immediate implantation on the septal areas, because septal bone is relatively very thin, so we place the narrow diameter, and the socket preservations and the collagen graft coverages, and 1 month later, relatively very shortly, we making through the temporary to the final processes. As you see, the only one side is, however, is a freehand cases, and with the zirconia, milling sintering, and placed into the mouth, we have a very good occlusal contact. So about the details about how to take a very precise occlusal contacts in a freehand cases. And in these times, I will very shortly concept about them. However, we place the narrow and short implant with the Bright implant system is very satisfactory. So nowadays, another challenge into the science to little bit overcome the guideline of the previous one. So for the crestal approach, is a relatively thin bones, and we tried to. So this is the sum of the case. We tried to crestal approaches is with the collagen graft instead of the bone grafting. So with the collagen graft tenting effect, we have a relatively good result. So some more magnifications, and with the only sinus lifting crestally with the collagen graft, and there is a very good elevation over the 5 millimeters with the collagen graft is very safe. So, but during the healing, there is some remodeling, and some bone formation became to be downwards. This is a clinical photos, And with some distal molar driving and through the temporalization, we have finished with the final processes. So about the crestal approaches, some doctors is very negative because there is a blind technique, also preparation and irregular augmentation is a problems. But with the collagen graft over the 5 mm augmentation is safe and even elevations. So in these cases, we need to do augmentations, and for the first molar area is try to do bicortical fixation, and the second molar areas is crestal approach, and with the collagen graft, and finally is a genocollagen was applied. So this is a collagen graft, is a genocollagen. So because without any calcified bones, and we can do exactly define how much it was elevated, and also how much bone will be formed. So that's the reason we have changed the effort with the collagen graft and later on, and to adding a genocollagen materials. And also, but sometimes, some is a very little bit difficult cases also we do the lateral approaches like that. It's like some, because retention system site and with that on the site, so we do removal of them. We also do the lateral approaches. In this patient have some problem in the basolateral sinus areas. This is a mucosal retention cyst, and in this side is maybe very similar fasciitis. So at first we did the surgery on this side, but later on, if possible, we tried to on this side for removal of them. This is a video of the lateral approaches, and I will show you as interesting. So as you see, before the surgery, there is a very big sinus area is relatively opaque due to mucosal retention cyst. So we decided to sinus lateral approaches for removal of them, press the implant. So also anterior two premolars have a problem, so we designed two extraction of them. But first premolar condition is not so good, but second premolar condition was relatively good. So we tried to place the two implant in the second premolar areas and also first molar areas at first for the temporalizations. Later on, we tried to one more additional implant. So clear-cut the periosteum. Yes, and this video is about some our clinics and some lateral approach concepts. And sometimes the extraction socket can be another source of the infection, so we do a little bit aggressive irrigations for try to remove all of any pesticides. And also little bit grinding out like approach techniques. In the lateral side, relatively high speed. So if the membrane is exposed, and we tried to perpendicular approaches to prevent the grinding out of the sinus membrane. So initial detachment is very important. So with a small round burst after the initial detachment. And after that is a little bit widening, and that reason is that to prevent the grinding out the membrane. But sometimes if you do grinding out the membrane, that can be a cause of the membrane perforation. So step by step, sinus detachment from the small instrument and to the longer implant. So from the distal, lower, and the anteriors, and after the detachment, and we tried irrigations to remove all of the anything. And after that was because the retention cyst, so we can do removal of them very well, simply. Also, with the instrument, we can remove sometimes with the suctions, and we can do removal so well. And there was two walls in the lower wall and the upper wall. So lower was perforated after removal of them, but upper wall was intact. So very simply collagen graft was placed to cover the lower populations, and after that we do genocollagens applied. Genocollagen was applied. Instead of the particulate bone, is a genocollagen is much more easy to manipulation. Also during the bone remodeling, it's a much more even bone formation compared to the particulate bone. So a long time ago also we had placed the particulate bone. Nowadays also already from the 10 years ago we placed the collagenate bone into the sinus. And also we tried to place the 2 implant in the molar areas. The other video are safe, so I will skip. And after the surgery, and 1 year later healing, so the healing was relatively faster. So So 4 weeks later, we make a temporary crown with a cantilever in the anterior and the posteriors. But there is a very limited contact in the lower, so we place the temporary crown relatively earlier because the implant stability is relatively good. So next, about the narrow diameter implant. However, we use the very narrow diameter implant in the 3.5 implant in the lower molars, and over the 400 megapascal that can be used for the single molars. So for 3.5, especially tissue level implant can be used for the single molar very successfully. This is a very narrow diameter, is a maybe 2.3 diameter implant. It's not the bright implant, it's a simple line. Because the alveolar ridge is a bone is very narrow, buccolingually, and also vertically bone defect. So we placed the 2.3 millimeters diameter is a slimline implant into the breast in the missing area, and there is a collagenate bone and the collagen graft together. After the final processes and during the follow-ups, and there is a relatively very good bone remodeling and also soft tissue clipping attachment. So we have a very good result with the narrow diameter. Also very good result of the collagenate bone and the collagen graft. So that's the reason, and from time to time we change the bone augmentation from the conventional GBR with the particulate bone and the collagen membrane to is a collagenate bone to the with the collagen graft. So with the higher is a clinical photos, as you see, is the bone is too much narrow and thin. So also we're taking a little bit autogenous bone in the lower part, and that was added to cover the implant site, and over there with the collagenate bone and the collagen graft applied and the sutures, and after the finals, and 9 years later, we have a very good result on the narrow diameter implant in the lower anterior. With that is a surgery, and most of the treatment became to be very simplified. Also in the upper anteriors, after extractions, after the bone resorptions, and there is some shrinkage of the bone and the soft tissues. So we had to place the very narrow diameter implant in the upper anterior side. So this is a very common healing after upper anterior extraction due to some bone loss. So 6 months later, when you do a flap elevation, we can see that and the very narrow alveolar ridges. So with the 2.5 implant and the 3.0 implant, and however we place the 2-point diameter implant, there is some fixture exposure. So we graft the collagenate bone and the collagen graft together, so on the side. Also in these areas, when you do evaluated the bone around 1 millimeters. So usually the ideal remaining bone on the labia side recommend at least 1.5 millimeters, sometimes 2 millimeters. For them, we must do additional augmentations on the labia side. But with the narrow diameter, is the concept of the ideal labial bone became to be different. So after the final processes at that times, with the collagen graft, a little bit more thickening on this side, But in the without any bone grafting site, is a very thin gingiva, and so most of the cases we place the conventional implant, there will be a gingival recession and the bone will be resolved in the cluster areas. But during the follow-ups, and the very thin bone was maintained very well, and with the collagenate bone and the collagen graft is very successful in the follow-ups. So in the CT images in the central, for the 11 tooth areas with the grafting is relatively well matured, and also in the 21 tooth area on the labia bone, however thin, but can be maintained very well. Also is another implant on the another side, and also we have placed, and that bone was very well maintained. So when you think about ideal bones, and there is a very common standards, but with a narrow diameter implant, we can change the concept of the ideal labia bones. And also this is another bone implant is a very narrow diameters because the bone, after extraction bone was too much thin. So for the conventional implant, we must do very extensive surgeries, but with the narrow diameters, we finish the surgery very simplified. So as you see, the before the surgery bone is too much thin, so we try to place the implant only into the cancerous side. So that's the reason we have selected the 2.5 diameter implant, very narrow one, and at the time of the surgery, 7 months later, and so we can feel that bone can be remodeled. So after the finals, and also we can see the surrounding the bone is very well maintained. So before the surgery, this is a video of them. At first, we tried to minimal incisions, or sometimes we can do the surgery without incisions. But its alveolar is too much thin, so that's the reason we tried to very small incision to check the bone is buccal and lingually. With a periodontal probe, or sometimes it's a pin-guide instrument, we check the buccal lingual width. Also, this pin guide is a very good reference for the labial bone volumes, and also we can place them into the palatal side. There is two types. It's a full pin guide system and a simple pin guide system. But simple pin guide system is disposable pins, and also they can carry by the needle holders. Also very easily vented. So at first we tried the minimal incisions to check the buccal lingual bone width. But bone was too much thin, so we tried to extend the flaps a little bit more larger. So after flap elevations, so vertically some bone resorption and horizontally too much thin. So with the normal way, however you use the pilot drills, sometimes that is too much thick. So with the high speed, we do making some first drillings, and after that, change it to the pilot drills to follow the cancerous regions and between the buccal and the lingual cortical bone. So after the parallel pin positionings, and palatal bone also still very thin, so we place the collagen graft. The collagen graft is not only for the thickening of the soft tissue, and also some bone formations, because there is a two layer, one is a thick layer, and the lower one is a very loose areas. Before the resorption of the thick layer in the lower loose areas, there is a tissue formations. Finally, there can be a bone. So that's the reason we place the collagen graft on the palate side together. But on the labia side with the xenograft, we tried to finish the surgery very simply. After the suture and was finished. So after sutures, and also in the number 12 tooth, we placed the root canal implant to save the tooth, and after healing, making a temporaries. But after the healings, we can feel that there is, if you do a little more soft tissue augmentation on the labial side, would be fine. So that's the reason we make an incision on this side and the position on the labial side. So after the position and the healing abutment, and during the healing, we have a little bit more soft tissue on the labial side. So through the temporarization again, and after that, we try to make final processes. At the time of the final processes, we decided to make a screw on the labial side. Of course, before, in these situations, we try to make a final process. Sometimes it's a cementation type. Also, sometimes try to benting on the palate side. But if the patient is not so much high expectation of the aesthetics, sometimes we do make a screw on the labial side. Because there is a development of the zirconia primer and including the 10 NDP materials. So with that, we have a little bit chemical bonding. So this is an anterior case, posterior case in the single molars. After the extraction, we place the implant in the septal areas. After that, all very similarly with the previous cases, very narrow diameter, the septum, and the implantations, and the collagen graft healing, and through the temporary crown, and we make to the final processes, and with some effectiveness of the collagen graft is distal side is a little interproximal spaces can be filled with the soft tissues. So collagen graft is some effectiveness, the soft tissue thickness that is sometimes very effective in the very thin gingival or interproximal areas. So this is a history of the development from the particulate bone to the collagen membrane, and over there also recently we have launched resorbable packs that is named like bright oral packs. And this is a history of the bone graft materials. At first, we tried to develop the synthetic bone. Nowadays, a xenograft have a very good feedbacks. As in a histology, so in a long time you have a question of why xenograft is better. So higher magnifications, and also there is a very small roughness would be effective, and also low crystallization of the hydroxyapatite is effective. So we still continuously to upgrade it with the adding of the silicate like that, and to more bioactive bone formations. In animal studies, and also at the 2 weeks, some bone formation, but 4 weeks later, in a vertical situations, bone was formed very well. So also about the tissue level, already mentioned, this 3.5 implant can be used very well. So we have a very good result. And the next about the CT powered by AI, before and some of the lecturers have presented so well about the CT viewers, but we also nowadays developing of the facial photos taken by the conventional CT, and that is a very same magnification and matched very well with the CT soft tissues. And already Dr. Popong and other doctors have mentioned of the stitching together of the facial scanning and the CT imagings and the intraoral scanning all together. And we have launched a CBCT, and also very interested in the facial scanners, and they're from the very cheap one to the expensive one. But if data attached all together in the convenience, it would be very effective, convenient. So we tried to stitching all of them, but this is a software a little bit different. So in final goal is automatically stitching all of them very simply. So this is maybe in the CDEX, 2 months later we launching on the CDEX with the facial scanner, bone scanning, and the intraoral scanning together. And for that, and also another approach is for the X-ray taking. Before, when you try the panoramic or CTs with the bite hook and through demobilization of the patient. But with that, it is very difficult to check the AOA and the TM joint. So nowadays, we have tried to change the concept of the CT taking with closed mouth. So before, instead of the standing and with the sitting positions, and instead of the bite poking and with the closed mouth, and also we try to develop the stabilizing devices. And with the left is a standing, right side is a sitting positions. Compared with in the same patient, because the patient ages became to be higher and all became to be aged and aged, so sometimes the patient cannot standing without motions. So in the same patient is depend on that is became the age became to be higher, and so the motion control is much more difficult. So that's the reason we recommend the sitting positions. And already so AI with the AI denosing technique, X-ray dose is much less. And that means before 1 times CT X-ray dose is nowadays 5 times CT X-ray doses. So that's the reason we can do CT taking much more easily and freely. This is a view, and before when you do taking 100 times cut, nowadays only 20 times cut is good enough. Very similarly, there is the AI denosing technique. This is a metal artifact reduction algorithm. Also, with this algorithm, however patient have a metal, we have a very clear images. So Professor Won have mentioned that at the first lecture is with the titanium without any metal artifact, and we have a relatively very good surface image of the metal, and that can be used for the CT check bite. So we previously two hidden algorithm, and also is exposed the BO algorithm, AI segmentations, and also the virtual face and the AI occlusal frame, and the cephalometric, and also for the deodors, and can be applied step by step, continuously applied, and that is very effective for the diagnosis and also treatment. Also, before the endodontic treatment, already we know the presence or not of the MB2. So that is very helpful for the endodontic treatment. Also, tooth segmentations for the clear aligner, and we can see the root to parallelism very well. And also AOA, the others all together. And through the stitching of them, and also we can see the AI occlusal frames and the midline supported by the AI, and that is very helpful. Of course, a prosthodontist is much more familiar to check the occlusal frame and the midlines, but only depend on the soft tissue is relatively very difficult to define the ideal midline. But that was combined with the hard tissue images, so we can sure about much more exactly midline. So however we we have used the facial scanner and the smart design, most of the cases with the mock-ups, with the wax or the resins and try in. But with this algorithm, and we can do that without trying, we can finish the final processes. So that's the reason we making a consensus topic with the minimalism. Also, the other segmentation is that even into the sinuses, the treatment is very simplified. Another recently interesting approach is AOA. Before AOA evaluation also can be done from the cephalometrics, but with the compensity, with the three-dimensional evaluations, That with that, and also we can control the snoring and the sleep of the amnesia. Also, is recently we are focused on the TMJ analysis and the treatment because with the development of SNS and the handphone, however, aged patient is too much parafunctions and the TMD problem. So with the 2D images, and very difficult to define. So most of the TMD treatment is done by the symptom-based approaches. But with a clear image of the convincingly, and we can have a much more tools for the diagnosis. That is very helpful. So, but not only the segmentation with the coloring in the condyle head or temporal bone, that is very effective. So with the treatment or TMD treatment, and we can do feel, sometimes we feel the difference or we feel some differences. So this is also, so that's the reason in most of the cases we recommend the convincing technique, convincing with a closed mouth. With the openings, it's very difficult to check the TMD and also airway. So in this patient is cases applied all of the CTB AI functioning. Before the treatment and after the treatment. Before the treatment, patient is a loss of the posterior side, and so that's the reason, and some deviation. So we to collect the data is intraoral scanning, and the CTB view, and stitch the all together. And with that, from the CT viewers, we already know the midline and the AI occlusal frame. That is very helpful for the virtual setups. And through the virtual setups, we became to know that which tooth is the supra erupted areas, and which area is a little bit collapsed. That is very helpful. So with the breathing increasement, and we can do additional virtual setups. And also with the virtual setup is very helpful for the communication and the consultation with the patient. And so we did the surgery, and also in this area is the bone was relatively thin and the pontic area together. So we did some very simply collagenate bone with the collagen graft. We finished the sutures. In the lower side are same. And after the surgery, and also we try to save the tooth and with the root canal implant. That is insertion torque less than 5 Newton centimeters, so a little bit mechanically and chemically bonded, but that was developed around 10 years ago during the evaluations. Very good prognosis. So we have used many cases to try to save the tooth with this root canal implant with a little bit crown lengthening procedures and the check bite. With the breathing increasement in the virtual articulator and the virtual setups, and with that, and also in the intraoral scanning, we can see that in the pontic area is a soft tissue is labelly augmented or not. And after the virtual setup and the temporal crown pressed into the mouth. After that, and also at the time of the finals, and there is 2 types of the check bite, and also Dr. Won Young-do have mentioned that there is 2A with a reference point with the check bite, or is a one-time compensated taking is also a very good check bite. So in this patient with the CT check bite of the implant, that is a very helpful. With the temporary crown in the portage for the demobilizations of the lower jaw, and so with that we have a very clear image of metals. And through the stitching procedure, we making a virtual articulator, and through the stitch, this is the stitching procedures, and we making some virtual models on a virtual articulator. And so sometimes if the breathing is not good enough, we try to do 2 millimeters additional build-ups for the final processes. Usually for the finals, we must do, we have sort of that, and we must do that only through the provisional crown. But when you do evaluate the virtual articulator conventional to the compared to the conventional articulator, but virtual articulator is very accurate. So sometimes we making a, however, with 2 or 3 millimeters breath increasement we do, with not through the temporalization, is directly sometimes we do making a final processes. With these cases, it's not through the, however, with the 2 millimeters more virtual articulations. Of course, many of the cases also through the temporalizations, but in this case, without not through the temporalization, we go to the directly final processes. So after that, and in the virtual articular century and the eccentric, we became to know that that is very accurate. So most of the cases, even in Pullman's cases, we making a final processes without any models. And pressed into the mouse and finished it during the follow-ups, and the occlusion was relatively good 3 months later. And this, as continuously we do check the occlusions, and the occlusion is very stable and good context. So before and after the panoramic view. So this stitching is very helpful, especially in this case, the CT check bite was very helpful. That is very good for the, especially on the Oronex cases. And also from the CT image after finals in the midline occlusion check is very similar with the virtual articulating, virtual setups. The facial portals is debated, chin is a little bit collected. Also in this patient, before the treatment, after treatment is airway changes we can follow on the compensity. So that is very effective. Also in the orthodontic treatment, in the before the treatment, this AI occlusal frame midline is very helpful. So before the orthodontic treatment is one side is hypoocclusion due to tilting, so one side is infraocclusion. So also midline deviation we also checked together, so that can be very effective. This patient is a class 3 patient, and before the treatment, or during this patient have some problems. So when you do evaluation from the compensating, patient lower chin is deviated. We became to know the deviated also occlusion is tilted. Sometimes also we can check the yawning together. That is very helpful for the evaluations. So with the segmentation also we can check into the sinus cavity. Also cephalometrics. Automatically, each tooth can be segmented. So more companies launching very similar BUs together. So with the development of the AI, the treatment became to be accurate and simplified. So AOA is, from time to time, we became to know that is very important because auto supply to the brain is very important with Alzheimer like that. So before the oral treatment, after oral treatment, and we became to know that AOA became to be orphaned. Also in this patient is before the treatment, after the treatment, we need to check the AOA. AOA became to be orphaned, so patient is mentioned is much more fresh at the morning after the waking up. So we tried to make some sleep devices, and of course it's like a CR split like that with a 10 millimeter 8 to 10 millimeter thickening in the upper part is very common for the control of the sleep amnesia or snoring. But we tried to better thin in the lower, but the design not extended to lingual side to make a much more tongue space is also important. So from the canine area, a little bit incisor covered. So with that, and we became to the AOAs became to be orphaned. So this would be another very interesting approaches in the futures. With that design, that covered the lingual surface to make a much more space for the tongue. So also with the breathing increasement, we do check the AOA. Also another interesting checkup is about the TM joint. So this is already shown with the segmentation and the coloring. We can see the much more detailed evaluation because 2D image is not good enough for them. So in this patient is a crest division 1 cases. So with the too much bite, patient have some difficulties because lower teeth is too touched to the palate is sometimes painful. So we decided to breathe increasement at the upper anterior side for retrieval of the upper teeth. We placed the implant. And with the temporization, and on this side, when you place the implant, intentionally, implant is tilted to the labial side to making a space much for the tongue. So before the treatment, after the breathing increasement, AOA, we became to know that AOA is much more opened. Also in this patient, and before and later after treatment, and we can see that some more spaces after the breathing increasement. So this is a very dramatically differentiated. But some patient in a CTB are little bit very difficult to differentiate between the before and the afters. But when you do with the rotational movement, and when you do carefully examination of the TM joint point, TM joint is spaces, we can see some differences after the treatment. So when you do sometimes with the TMJ locking patient with the TMJ manipulations, we do some after that, and we do progress therapy, we can face the TMJ patient is mouth opening is became to be much better. So before the progress therapy and after progress therapy, we do check. But sometimes that is not good enough. So another interesting approach is of ours is only one side, especially first and second molar is breathing increasement. And with that, and from time to time, we can, at first the patient after increasement, the contact area only one side. But during the follow-up, we became to know there is a bilateral contact. Patient is jaw little bit tilted or rotated, and with that is in this CT image is a little bit difficult to define, but we can feel that some gaps became to be opened. So patient became to be comfortable on the right side because the patient have some crepitations on the right side, but that was controlled. So with that concept we tried to reduce the crepitation on the right side. Not yet completely we can assure that, but with a clear image of the TM joint, that is the way for the treatment. So perioral argumentation is very interesting. Is a PDRN, PN, PHS. Especially PN is a very stable and good materials. So not only the skin boosters, that was the industrialization as a wound dressing. That is very effective for the TMJ progress therapy. And because the PDRN, before PDRN was good, but PDRN is a solution, so effectiveness not so much longer sustained. But PN or PH is a gel and much more longer effectiveness. So this locking patient can be solved with immediately after that. One is writer and also TM locking was relieved. So this is a PH injection in the TM joint. So patient have some locking problem. So at first with the TMJ manipulation, and the patient can be opened. After that, we tried to progress therapy. Of course, at first is the familiar, but with 1.5 centimeter from the tragus, or 2.5 centimeters is that was the anterior and posterior position of the temporomandibular joint. So at first tried 2 injections to find the space with the mouth opening. That is at first it looks very difficult, but if you do 1 or 2 times, you became to know that is a very simple therapy. So through that direction, we do injections, PH or PN, that is developed for the wound dressing. So another interesting approach in the orphantrial is a very severe bone destruction. So we press the implant and the bone augmentation on the labia side. This is a very interesting cases. 3 months later, burial osseointegrations. But before the surgery, as you see, as a labial bone is very severe defect. So we do implant, but stabilization was a little bit difficult. Only apex areas we have stabilizations and bone augmentations, but also pH can be applied together. But at the time of the temporalizations, but compared to this position and this position, you can see that the position was a little bit different. Implant became to be tilted on the labia side. But osseointegration was successful. So we think that PN is very effective in also bone formation. So that's the reason, as during the bone formations, that is clinged to the implant on the labia side. Also, is implant stability, PN is very successful. After drilling, if you inject the PN into the drilling site, we have a very good initial fast osseointegrations. Also, in this case, okay, thank you. And also, sometimes in the patient of the treatment, like especially class 2 patient with the injection of perioral augmentation is very satisfactory of the patient, and that can be really very changed aged patient, not only for the aesthetic to satisfy to making of self-confidence of the patient, especially in the aged patient. This patient is 81 years old, but was very successful before the injection, after injections. And 3 months later, patient appearance became to change. Not only the appearance changes, but also the mind is too much changed. So this is final videos of that. And thank you very much for your interesting.